All right, I think we've got a critical mass here. Thank you, everybody, for those attending and joining us today for this discussion. I'm very excited about this. Uh, Over the last few months, a number of newsrooms around the country joined together as part of the Indigenous Investigative Collective to investigate the impact of COVID-19. Using public records laws, data analysis, and lots of reporting, they started to piece together the ways that key decisions impacted communities around the country during the COVID-19 crisis, with a particular focus on members of Navajo Nation who saw some of the highest COVID-19 rates and why that happened and how much data we are missing to really understand the full story going on. Just a quick note before we kick off that this session will be being recorded and we're going to have time at the end for all of your questions. So please drop them into the Q&A field or use the chat box and we'll get to them at the end. With that, I'm going to hand it off to Christine Trudeau, who was the managing editor for this project and who will be moderating this discussion. Christine, thanks so much for joining us today.
Thanks, Michael, and thanks everybody for coming. And thanks for this opportunity to talk about this, this work that we've been doing the last 6 months. So like Michael said, last January is when we kind of started digging into this, but the previous year in May of 2020, the Navajo Nation reported some of the highest per capita COVID-19 infection rates in the US. And we decided to start kind of digging into that by looking at medical examiner reports in counties surrounding the Navajo Nation to try to get a better look at that snapshot. And in filing those requests, those were slowly one by one denied. So our reporting kind of took a look at how we might get a better understanding of why that might be. And then we're also joined by Joe with the Colorado Health Institute to talk about some of the data issues that come up and why those might be a problem and are a problem. So yeah, if I guess we should probably start, if you want, Jordan, just to talk a little bit about how you started working on this project and the components that you focused on with the report.
Sure. Hi, everyone. Yate. I am Jordan Benebigay. I'm with the Indian Country Today. And I guess as part of this project, I focus on more like the national perspective for Indian Country and, as it relates to the COVID-19 impact and just the huge COVID data problem, right? That's been happening during this pandemic. And what, I talked to various individuals, I talked to funeral directors and, researchers like Abigail Elkahawk just to see what the issue has been. And that's been over the past year. So I kind of already knew what could be the problem, but just following up on that right after. And even since the beginning of the pandemic up until now, and actually just decades before this, one issue that kept popping up was the constant racial misclassification on death certificates when it comes to recording COVID-19 deaths, right? And how who records, the cause of death on these death certificates. It could be physicians, medical examiners, coroners, and just wondering if families are consulted. So I talked to an individual up in Minnesota, and he is a native funeral director, but he, talked about how he would consult with the family and try to be as accurate as he can in filling out these death certificates. But what was really interesting was he said that he'll just send it off to the state vital statistics, and he doesn't know what happens from there when he records race and ethnicity for individuals who are deceased. And for him, he also talked about, he'll write down whatever the individual classifies as, and it could be multiple races. And so he records all of that down. In the case for Native people, he even talks about how if they're descendants or if they're enrolled citizens or community members, that he'll also record that in the death certificate. But again, it's not up to him, it's up to the state. On the other hand, there was also Abigail Elkahawk, who I talked to, and she said much of the time, a lot of these doctors don't consult with family, and doctors will sometimes fill out death certificates also. And even in California, several months ago, one of the directors for the California Tribal Epidemiology Center was saying that it's the same thing. Like a lot of doctors will assume, somebody's Hispanic, and sometimes, they refer to the surname, and a lot of Native people in California have Hispanic surnames, so they'll automatically assume somebody's, Hispanic or just of Latin descent. So that really causes issues in trying to just aggregate the data, after the fact or even like during. And another one, it was just talking to IHS and just seeing how they're recording these COVID-19 deaths, and also reaching out to the CDC and seeing how, the big picture data, how they're capturing all of this. And, the Indian health system is so interesting, and it's really complicated, right? It's not just IHS direct facilities, it's also urban Indian health programs, private hospitals, VA hospitals that makes up this whole system. And there's really no unified system to record all of this data, right? A lot of tribally run health facilities and direct health facilities, they also run off of different electronic medical record systems, and so they don't talk to each other. Same thing with on Navajo. I think Sunny, who was working, focused more on Navajo, she was talking about how they exchange data by fax, or even the CDC. Abigail was saying the CDC also would get data just in various forms, right? PDF spreadsheets, there are just so many different ways this data can come in. And sometimes this lags behind, sometimes they just all don't talk to each other, right? And there's also with the state relationship with a lot of these tribal nations as well. They don't have access to a lot of the state databases, so that also causes an issue too. It's just so many different, the data issue just kind of already came to the surface with the pandemic right now. I mean, these kind of always existed, but now it was really highlighted, in extreme circumstances. And I think it'd be interesting to see what happens after this. If people learn a lesson, and if it gets fixed, I don't know. But that'll be something to look into later on. But that's kind of like what I know it's really broad, but that's kind of what I looked at as the big picture for this story.
Yeah, and I think a good segue there in mentioning Sunny Kalashis-Chilagi is not able to join us today, but Tristan, if you wanted to touch a little bit more on the importance of Sunny's role and what she was able to bring into the piece, especially locally.
Sure. Yeah. Hi, I'm Tristan Aton. I'm with the Texas Observer. I helped edit the story. The Sunny's role in the story was really, really big for the on the ground reporting. Sunny has some great sources and contacts out in on Navajo Nation, so being able to interact with different clinics, interact with different folks that are out there, and really gather that on the ground sort of real time data was really, really important. So we were really happy to be working with everybody, since we could sort of like put everybody into different roles to grab different parts of the story. And Sunny's work was definitely invaluable in getting on the ground.
Yeah, and I know you also mentioned data, and it made me think, Joe, if you wanted to talk a little bit and just reintroduce Joan Hanels with the Colorado Health Institute, talk a little bit about the data issues, specifically with misclassification. I know that's sort of a broader issue that impacts a lot of data, but if you wanted to kind of maybe talk a little bit how that specifically impacted the COVID data.
Sure, I will do my best on that. Yeah, I'm Joe Hanel. I'm with Colorado Health Institute. Real quick about us. We are a independent, nonpartisan research institute, and we exist because we believe that data and evidence can lead to, if employed properly, can lead to better policy making. That leads to, and policy is a key to improving health for everyone. So we've done that for 20 years or so now. And we obviously data and analysis and like informed use of data plays a really big role in, or has played a really big role in the pandemic. And Christine, as you said, I think there were, or no, as Jordan said, there were issues about how data are reported way before the pandemic. It's just really come into stark relief now. My takeaway is that our data systems just are not set up for this rapid reaction to be able to spotlight problems in individual communities. They are, it just by its nature, things are more broad. And also, since we're talking about health data, there are privacy rules that come from a very well-meaning place to protect people's dignity or protect families and survivors. We run into this, we used to run into this a lot when we were talking about drug overdose deaths. That was kind of the pandemic before this pandemic. And we would collect data on a county basis because it's county coroners who sign death certificates. And then we would want to be able to say, all right, we would want to be able to track the number of overdose deaths in each county, say, and see a trend in like 10 years or so, how things are growing. And the privacy protocols say if there's below a certain number of deaths, that number will be suppressed in public reporting, because we have counties here in Colorado that have 400 people in them, total population. So if you have 1 or 2 overdose deaths, then you could, somebody who's carefully looking at it could say, oh, so that might be why so-and-so died last March. It was never really explained. And then there's possible stigma for the surviving family members. So that's where that comes from. Definitely in Colorado, a death certificate is not considered the full data on a death certificate is not considered public record. So you can't just file an open records request and say how many people who are with a racial identity of Native American or mixed race or whatever, what have you, died of COVID-19. In this pandemic, we have even more, especially in the early days, it was even more difficult because nobody knew any of the data. It was a new disease. It was here before we knew it. So if you don't mind, I'm going to share my screen and just go, I'll show you this is the Colorado data dashboard for COVID-19. And right now we're just looking at a case summary. This is kind of the first look. I like to look at 7-day averages. It smooths out the data quite a bit. Unfortunately, this is where we are today. You see the run up here. It's happening nationally. What's disturbing to me is we're at about the same case rate as we were right here. Do we have this in front of us? Probably not, because so many people are vaccinated. But we were really hoping that that this fall would continue and this would be in our rearview mirror. So all this is to say that this is still a current story. We're not delving into history here. We are still dealing with COVID-19 and its very disparate impacts on people throughout the West. Here is what I find to be a really fascinating graphic that illustrates my point of it being the data being not just hard to get, but non-existent in the early days of the pandemic. You see the normal pandemic curve that we're used to seeing, the big surge here in over the fall and winter. This, though, is still from the State Health Department in Colorado, and it's looking at the number of cases by the week that symptoms were reported to a person's medical provider, rather than by the date that they came, that the positive test was given, because people might have had COVID for 2 or 3 weeks before they had a positive test. March 5th was the date that, March 5th was the date that we, that the first COVID was first detected here in Colorado. And something just blew up with this dashboard. Come on now. I'll try on something. All right. March 5th was the date that it was first detected. But here we have already on that day 33 cases per day being detected. If I could show you, let me try to show you the week again. Is it going to load for me? Did Big Brother just discover that I'm showing off this awesome secret data here? It's publicly available. Go all the way back to on the weekly one. So COVID-19 was revealed to the world by the Chinese government on December 31st, 2019. That's the first mention that there was a novel respiratory virus that was circulating in Wuhan. If you would go look at the weekly data here in Colorado, you would see that the symptoms were already reported, and there were more than 20 people in Colorado already reporting symptoms the week of the last week of 2019. So COVID was here, it was circulating. In all probability, people were dying from it fully 2 months before we knew it was here. We were watching it spread, thinking, oh, it's going to be here soon. I remember it was big news. Some tourist in Summit County at the ski resort tested positive for COVID. He was just the first one to test positive. There had been dozens of cases before then. So that's a bit of a look back at why data weren't available in these early days. And then this curve here, we know that probably it should be almost the height of that curve. We just didn't have the testing infrastructure, because if you remember back to February, March, April, Centers for Disease Control, I'll basically say it, botched testing, and there were not enough tests to go around. So people were getting the disease, they were going to the hospital, some of them were dying, and COVID might not be marked on their death certificate. So another weird way that Colorado started reporting deaths and tried to get around that, or tried to account for that, was there are 2 figures reported for deaths in Colorado. First is this, we see this is the current dashboard, 6,924 deaths among cases. that number used to be larger. At some point last fall, these two numbers crossed. 7,190 deaths due to COVID-19. Those are people who have COVID-19 listed as the cause of death on their death certificate. And that number used to be quite a bit smaller than this deaths among cases, because these were people who had COVID-19 and died, but COVID-19 wasn't necessarily listed as the cause of death. Could have been pneumonia, could have been something else. Trying to get at this controversy of, are people really dying of COVID, or is this just a disease that old people are getting and dying anyways? That's complete bunk. People were dying of COVID. At some point last fall, this first number ceased to keep up with the actual death certificate data. So now this is a more accurate number, but it could very well be that there's still a lot of people dying of COVID, and it's not listed on their death certificate. That is a decision that's up to the county authorities, really. And then race and ethnicity data is, again, a really, what Colorado reports is not all that useful. I mean, it's useful in saying there's a disparity here, but it's not as, that's about it. So the state does report on Centers for Disease Control data, but here we see, 1% of the deaths in Colorado are American Indian or Alaska Native, the census category. 76. Is that really the number, or it's probably close, but we don't know anything about the geography where those folks were. Were they in a tribal reservation? The largest Native American population in Colorado is here in Denver, where I am. We can't match it up with income or anything like that. There's just a lot that is unknown about these numbers. One thing we do know is that people identifying as Hispanic are this 25% number. That is that's larger than the total population in Colorado, I believe. So this is a disease that has visited ethnic and racial groups in a very different way.
Right. And can you just talk a little bit briefly about how the collection has and reporting has created a problem? Because I think you're only have reported as large as a county level.
Right.
Can you talk a little bit about why that?
That's been very frustrating for me. There are states that will report cases at the zip code level. Again, you get into privacy rules there. The smaller the geography is, the more likely you are to have to suppress data based on the current, based on what the privacy rules are. We tried to get around that, and we're able to do so in a way for the Denver metro area only, because we helped build a data source here called the Colorado Health Observation Regional Data Source, or Data Service. And it takes data from medical records and makes them anonymous, so there's no HIPAA problems, and makes them available for public health research. So we did this in Denver and just published this this month. the darker the color, the more cases of COVID relative to the other census tracts in the Denver area. If you're familiar at all with Denver, this is basically downtown. Interstate 25 runs through north-south, Interstate 70 east to west. And then here's a neighborhood that is often lags in a lot of different health outcomes. The largest number that we saw here was in right here in the Westwood neighborhood, 2.5 times the average rate. This is also a census tract it's either this one or the neighboring one. The Denver Indian Center has its headquarters, and it's just out of you can really literally the other side of the tracks. You have a much more well-to-do neighborhood and 1/3 the average number of cases. So it's like almost 10 times as much COVID in this one tract as there is, a 10-minute drive away. It'd be great if we had this sort of information on a national basis and in real time. What you're seeing here is only up to end of the year 2020. This was, and this is coming from just like, energetic public health researchers and clinicians at Denver Health, Kaiser Permanente, people who thought we can do this better. We can really like micro-target areas where there are problems with specific conditions. And so far, accords have been used to track like chronic conditions, like diabetes, smoking, mental health diagnoses. We tried to put it to use for pandemic tracking, and even this data lags quite a bit. The data is, it's 6 months old before we can get it out there in public. And 6 months, 6 days matters in this pandemic if you're trying to take interventions. That's why when I started out with here we are in a rising slope. This is a dangerous time, you guys. And the rising slope now masks a lot of action that's gone on below the sensitivity of our data collection systems. So, COVID was here in Colorado and spreading for 2 months before we detected it. And then the slope starts to go up. When you see a rising slope like that, there's a lot of bad stuff that's built in the weeks to come. So we just need some way to be a lot more responsive, and we need to be able to find a way, and I don't know what it is, but we need to be able to find a way to have demographic data as well. Age, race, ethnicity, education status, we found was very correlated with the spread here. And yeah, there's the risk of privacy rules, but there's also, if you can have better data coming in real time, then there's also you could save lives with it too. So that's a conversation I think public health and journalists should be involved and hold our feet to the fire here. Public health is going to have this conversation. Our policymakers are going to have to, our communities are going to have to demand it and say, tell us what's going on in our own towns, our own lands. You've got the numbers, we need them to make a difference. I'm sorry, I probably went quite a bit over on time, but that's my soapbox.
Thank you. I want to go to questions soon, but first I want to give people a little bit of time to think of them, type them in, and we'll go back to Tristan. And if you want to just share a little bit about the importance of organizing IIC and bringing us all together for this project, specifically taking a look at how COVID-19 has impacted Indian country.
Sure. Yeah. I mean, I think to Joe's point, there's, clearly some pretty serious data problems here. Is that we're not getting information in real time. There seems to be no movement in terms of actually wanting to fix those systems. They were broken beforehand and they're still broken now. That obviously, as Joe said, that not having that information costs lives. In the case of the reporting that we did with this particular story and more reporting that we're doing currently, we really dive into that to see what those impacts are, not only from not having that data, but what that'll mean for communities in the future when dealing with future pandemics or anything that is data related for that matter. So being able to work with a number of newsrooms like Indian Country Today, like High Country News, Searchlight New Mexico, really bringing in the talents of all those reporters to be able to contextualize that information in unique ways, I think is really important for journalists to be doing, and really serve as a model for journalists to be working together in more collaborative ways instead of sort of siloing our information, which has been traditionally what journalists do, I think, in terms of, finding a story and then keeping it to yourself. That isn't a particularly helpful model these days, especially in a time like this with pandemics too, because our information is just as important as the health information that we're trying to get. So making sure that people have access to that in multiple different platforms and forms is really important thing, I think, for reporters to be doing.
And then Jordan, I wanted to give you an opportunity to talk a little bit about what this collaboration has been like and any other insights from the reporting. I know it's ongoing, so anything that you feel comfortable sharing about your experience.
Yeah, I think I really enjoy just working with other people and just seeing what their strengths are and what their insights are. I think it was really great to have Sunny just on the ground because a lot of us can't be there, but she's there and she's able to bring that information to us and kind of confirm what we're already seeing from a broad perspective. And I mean, that's what ICT does, is just we look at, the national lens when we report our stories. I think it's just, there's very few of us, very few, Native journalists. And I think it was really great to put our heads together and to figure out what the story was here, and seeing how other people work and seeing how other editors and reporters go about was really helpful, at least for me, because I admire everyone's work from afar. So to actually work with all of them and all of you was very, it was just very, very valuable. And also, I'm able to bring those to our newsroom at ICT and continue to work with you all. So I found it very great to collaborate with other newsrooms.
Thank you. And so with that, we've got some time for audience questions. I think I see one in there. I'm not sure who could answer this. Any data on evangelical or extremist religious groups spreading COVID intentionally as proof of their faith and right to practice, or unintentionally as a way to give people a sense of security and or opportunistically to extend their missionary duty?
So the very short answer is no. There's not data about this. The data systems that we have are not fine-tuned enough to look into specific causes like this. This is where shoe leather reporting and on the ground knowledge of communities and sourcing would have to come in if this is actually if this is happening either in Indian country or anywhere else. Thanks to reporting, we do know that, and also to social media, early days of the pandemic, people weren't taking it seriously, and there were actually a few instances of people having COVID parties. Hey, let's all break lockdown and get together and have a party. Folks would think back to like chickenpox parties that people of my age, thankfully I never went to one, but some parents back in the 70s and 80s would, you know, one kid has chickenpox, hey, let's get them all have chickenpox and get it over with. That's turns out that's a really, really bad idea because chickenpox is a pretty dangerous disease. People were doing that with COVID in a few instances, and some of them got COVID, big surprise. But as far as that being a leading cause, I'm not, there's no data to show anything like that. What there is what I would love to have some hard numbers to put to is just a general sense of invincibility, or not taking it seriously, or believing in conspiracy theories that either it isn't real or it's some sort of government engineered way to control people. For the most part, people suffering greatly from this disease and dying from it right now are people who are not vaccinated. Some people are not able to get vaccinated. Some people still don't have access, to our great shame. And a lot of people, it's a political game for them to not get vaccinated. And they are putting themselves and their loved ones at grave risk. So that's more likely what we'll be able to see data from soon.
And it looks like we don't have any questions right now, but
I see one more.
oh, okay.
Joseph?
I didn't see that as a question, but
Oh, I see. Okay.
There's another one in the Q&A that Joseph put in here. I can read it. This is two narratives going on. One is that data isn't being collected because Fed and state governments don't care. Second, they're collecting too much without permission, attention to intervention or accountability about tribal intellectual property and privacy. Which one?
I mean, I think we may be talking about two different things here. We're talking about health data in terms of being able to collect COVID-19 health data through IHS or counties or zip codes or any of the different data collection resources versus collecting data for intellectual property or places of cultural significance. I think those might be apples and oranges in terms of the conversation here today. But I think, Joseph, to your point, yeah, there is a really high concern about collecting information that is important to tribes and indigenous communities. That's important and shouldn't be shared. But I think in terms of what we're talking about here with the pandemic and COVID-19, that is information that I do believe that we need in order to make proper decisions about healthcare and how we deal with it. And more importantly, I think when we came out of this story, I think the takeaways was didn't really know that the story would be sort of like hinting at the importance of a single payer healthcare system, but here we are. Kind of important to have a system that actually that isn't reliant on 18 different sources of information, and maybe I know it's a very controversial idea, but maybe having one system that actually handles that would be helpful. So.
Mm-hmm. Or even two systems too, because the tribal epidemiology centers, I see them as like the CDC of Indian country. And they are public health authorities, but there's also this tug and pull of if they are, even though like legally, I believe legally that they are recognized as authorities, but they're having issues with trying to work with states and trying to get data in with tribes too.
One question that came in, Jordan, for you, you talked about the mishmash of different authorities and different medical systems that people have to navigate and how they don't communicate. Has the pandemic, this problem's been around for years, has the pandemic driven any interest in kind of fixing that, or any real efforts to do that? Or is that still, people realize it's a problem, but people aren't talking about solutions at this point?
When I was talking to Abigail about this, I think the needle is moving a little bit, but again, it's hard because a lot of these, facilities are owned by different tribes, and they have different levels of, I guess, financial assistance, right? And so it's kind of dependent on that as well. I mean, the needle may move a little bit, but I'm just not too sure at this point if it will.
We have another question here too. Bridget, what are your next steps as a collective from here? I think on this, we're just continuing to take a look at COVID data, but also turning our attention to other investigations as well. Was there anything that, Jordan, you wanted to add on that?
No, I think just in terms of stories, because I didn't answer your question earlier, but what we're looking at, I mean, we're just looking at what kind of everyone else is too, is the long-term impacts of COVID, right? Not only for the long haulers, excuse me, but the economic situation as well. And see if from this story there is a huge, people were saying, a lot of experts were saying there's like an undercount of COVID-19 deaths among American Indians and Alaska Natives. Maybe see if that's even gonna, will we ever know down the road? So.
Thought I saw a question pop up and then it disappeared. Yeah. Was there anything you wanted to answer to that, Tristan, on next steps for the collective?
No, it's yeah, well, to echo what Jordan said, continuing to look at COVID-19, but also looking at a number of other broad issues, including, vaccines, jails. I mean, there's a pretty sore lack of sort of investigative capacity in the Indigenous outlets. I think there's just not enough support for these kind of projects. There's clearly a ton of talent and people who are able to take these projects on, but having any sort of infrastructure to really support this style and this type of investigative reporting is definitely lacking in tribal media or newsrooms that have Indigenous affairs reporters or desks. So if nothing else, this is I would say our future plans are to continue to just dig in, because technically, as far as we can tell, nobody else is looking at too many investigative stories in Indian country. We see stuff pop up occasionally, but I do believe that we're probably some of the first people to be filing FOIA requests, for instance, around the topics that we are. So I think it offers some exciting opportunities for what we want to do in the future, but definitely also signals that there is definitely a need of support for this kind of investigative reporting in Indian country, and specifically from the industry in general to really help that.
I think we had one more question pop up, just in terms of sort of collaborations with other newsrooms. A reporter in Michigan said that they've been working to kind of get similar data, and they're interested in sort of what are some of the broader collaborative opportunities, or if there's interest in doing data sharing more broadly with other newsrooms and groups, specifically regarding death data and sort of building up a better national look at some of these issues.
So the question was how to do that?
If you think there's interest in that, and just trying to kind of sharing, trying to spur, what would it take to kind of spur better data sharing among journalists around medical examiner data and other things that'll be useful for reporting.
Jordan, I saw you on mute. So.
I'm trying to read the question. I don't. So about a year ago, a little over a year ago, I mean, ICTV started our own database that we made publicly available, and it was just an aggregation of all the publicly available data tribes are giving about COVID cases, deaths, et cetera. And now we partnered with Johns Hopkins and handed that over to them because it's a lot for one person. And we've been working with more than 50 volunteers and with we're working with tribal nations to try to make a more comprehensive database. And that's, we want to make that publicly available, and we're trying to build, actually soon we're going to be launching the map for that. And I mean, that's going to be something that's available soon. But I think even just with this, I think data share is important. I think transparency nowadays is a huge deal among the public and in newsrooms. And that's something that's just been changing over the years and being more collaborative in that way. Like I said, the media industry is, in a sense, shrinking of a sorts. So I think it becomes more important to try to collaborate on these projects. I don't know if that answers the question, but do you have anything to add, Tristan or Christine?
Yeah, I mean, I know that I'm a contributing editor for High Country News and with the Indigenous Affairs Desk. And I know that we have underscore collaboration going on right now. Obviously this collaboration. So I think that is definitely the wave of the future for sure, for nonprofits, at least that I can speak to. Unless Tristan, you want to add something? I did see another question pop up.
What's the other question?
Oh, could you share a little bit about the success stories or difficulties you've had with public records requests? So yeah, obviously we had submitted, if you haven't seen our report, we've submitted to 4 different states. So the Colorado, Arizona, New Mexico, and Utah. There's multiple counties within those states that we specifically submitted for requests for this, for medical examiner data. And as we've shared, we were unable to get any of that because of privacy issues. So, I mean, in that sense, that was definitely a not a success in that sense, but it did lead us to kind of picking at more of why that is and trying to get at, the bigger issue about being unable to track it. So yeah, I think I don't know how much we can share about other stories of our successful reports that we've gotten back. I'll defer to Jordan's judgment and Tristan's judgment on sharing that, but we have been able to file other requests related to other investigations we're looking at right now that have come back with some good data for us. So yeah, we're just gonna continue to plug away at that.
I mean, I could say, and I don't know, Michael, you might want to jump in on this too. The biggest problem we have is just agencies not responding to our requests. So we've had, for instance, requests with Bureau of Indian Education that hung out for almost 7 months before even being acknowledged. So we have, the bigger issue is timeliness, and obviously during COVID, a lot of FOIA officers were not in office. That makes their jobs very difficult to do. But considering that agencies are back in the office or have the capability or capacity to do so, just having stuff hang out for 6 or 7 months is incredibly frustrating as a reporter to just sit there and check on it and see if anybody's even read the legal requests that you put in. So I don't know, Michael, you may have other thoughts on that as well, since you deal with this every day.
Yeah, I mean, I think we did see a lot of agencies really kind of slow down their processing last year. I think it's slowly, mostly returned to normal at this point. But yeah, the federal system can be so frustratingly slow, and local and state agencies can just be very creative in how they reject requests, or simply so many bad state laws in terms of making this inaccessible. But I think a lot of the folks on this call, I think, would be really interested in talking about collaborating a little bit further, or seeing what resources would be useful to Aaron who asked that question. I think that covers all of the questions. Thank you, first of all, to our amazing panelists, and particularly for the amazing reporting that came out of this collaboration. Thank you so much for sharing a little bit of the background and the reporting that went into it, and Joe for the expertise on the data side. We will have a write-up of the training with a lot of links and other resources there. And thank you again to everybody who joined us, and particularly Christine, thank you so much for moderating and guiding this discussion. I think everybody got a lot out of it, and we really appreciate that.
Thank you. Glad to be here.
Great. Have a wonderful day, everybody, and we'll talk soon.
Thank you. See ya.